Now check out this real fast exam and really get a sense of where the probe needs to be, where you need to be positioned to get the best views possible. When you approach the machine, you have to first select a probe or transducer. On most machines, there'll be a curvilinear, or in this case, we just have a phase array probe, and that'll work fine for the exam. On this machine, the Sonari, there's a transducer tab, and you select that and then choose your transducer. Right after that, you choose your exam type right here. And there's usually a fast or a general abdominal exam type. And here on the left button is our fast exam. So I'm going to select that. I'm going to take my transducer here, put an ample amount of gel right on there. Next is the patient and the practitioner position. Most people are going to start by standing on the right side of the patient. I'm going to bring the bed up here so I don't have to lean over, but if the patient was a trauma victim, we may just ignore this step. The ultrasound machine itself can be next to you or it can be across the bed. The patient needs to lay completely supine because we're looking for that dependent fluid. Bringing the patient's arm over his head will open up the rib spaces a bit, providing a better acoustic window for you. The indicator of the probe I'm pointing to right now is going to point towards the patient's head, and I'm going to place the probe very posterior in the patient on his right flank. I'm going to try to shoot in between the ribs here, and my knuckles are really on the bed, very posterior in the patient. So I'm just demonstrating that I'm going to just run up and down on the bed, and my fingers are right on the bed here. I'm going to turn the machine on, and right away we see the liver. I optimize my gain here. We see the kidney, the diaphragm, the spine, the lung, almost everything we need to see. Pretty nice Morrison's pouch view. And I slide up one rib interspace. I can see above the diaphragm pretty nicely. I'm confident there's no hemothorax. So I'm going to stay posterior, and now I'm sliding down a rib interspace towards the patient's feet where I can see the tip of the liver, Morrison's pouch, the entire view. I don't see any free fluid. And that's it. I'm done with the right upper quadrant. I'm going to apply a little bit more gel here. I'm going to move on to the other side, the left upper quadrant. My indicator of the probe is going to continue to point towards the patient's head or cephalad. I'm going to put the probe right here on the patient's flank, about one rib interspace higher than it was in the right upper quadrant since the spleen is smaller. And immediately when I touch the skin, I see the spleen. I'm a little too anterior because I can't quite see the kidney. Now there's the kidney popping into view. Spine's at the lower part of the image. As I go a rib interspace up, I can see the tip of the lung coming into view. Kind of obliterates our image as the patient breathes in. As I move inferior in the patient's body, I can see the whole spleen, lower part of the spleen, the lower part of the kidney right there. The lower pole of the kidney looks nice. I scan back up, spleen, I can see diaphragm, lung, everything looks good. So I'm done with the left upper quadrant. I can move on to the pelvis. Placing the probe right above the pubic symphysis with the indicator pointing towards the patient's head gives me a sagittal view of the pelvis. I rock the probe really low or towards the feet, and I can see the bladders, that anechoic structure you see there in the middle of the screen right now. I fan left or right, making sure there's no posterior fluid. Once I'm convinced there's no posterior fluid, I'm going to adjust my indicator and point it towards the patient's right. And now I'm getting a transverse view, there it is, of the bladder. So anechoic fluid, I'm fanning up and down now towards the patient's head and feet, making sure there's no posterior fluid. Now it's time to do our cardiac view. We're going to do a subxiphoid view. Apply a little bit more gel to the probe here. Now the indicator is going to still point towards the patient's right. Using the liver as an acoustic window, you're going to point the probe towards the patient's left shoulder. I'm going to hold my hand on the top of the probe. So if I put it underneath, there's just no space, and I can't kind of push underneath the xiphoid process. Right away, I see quite a bit of liver on the anterior top part of the screen. I increase my depth so I can get a full view of the heart. I should get a 4-chamber view. Sometimes you have to change the angle of your probe a little bit so you can open up the ventricles and the atrium. And really looking at the pericardium, that's that bright line around the heart, to really convince myself there's no fluid around the heart. And next up is a transthoracic view of the heart. So remember, it's just left of the sternal border, third or fourth or fifth intercostal space. My indicator is pointing towards the patient's left hip here on our machine. I get a nice view of the heart here. You can see the right ventricle on top, then the left ventricle, interventricular septum between them. See the mitral valve, aortic valve nicely. Clearly no pericardial fluid. I switch to the lungs. I'm going just to almost to the apex, but just the most superior portion of the chest here. I zoom in and I can see rib with shadow on either side and nice pleural sliding. There's a rib with shadow, nice pleural sliding. I'll check a couple other interspaces just to convince myself there's no pneumothorax. And I'm going to switch to the other side to compare and to rule out pneumothorax on this side. And again, I see nice sliding, lung back and forth there. Check a couple other interspaces. My indicator is still pointed towards the patient's head. And we're done with our EFAST. Now, I won't summarize the exam because we've gone through it twice, but let's talk about the management algorithm. If the patient comes in with stable vital signs and has a positive FAST exam, then you're going to send them to a CT scanner because you got to further delineate exactly what's going on. If they have stable vital signs and a negative FAST, then you clinically correlate, which means that there's some other process going on, or we're not really sure, we need further diagnostics. Now, if the patient has unstable vital signs, then the algorithm is quite different. So if they have a positive FAST exam, either they have hemoperitoneum, they have pericardial fluid, or they have a pneumothorax or a hemothorax. If they have hemoperitoneum, they need to go to the operating room for a surgical fix. If they have pericardial fluid, they may need an emergent pericardial centesis and eventually will need a pericardial window. If they have a pneumothorax or a hemothorax and they're hypoxic, then these patients need a chest tube for decompression. If they have unstable vital signs and a negative FAST exam, then we really should consider the other diagnoses that can cause an unstable patient with a traumatic injury. One important note is that you can increase the sensitivity of your FAST exam. You can change the patient's position with Trendelenburg or anti-Trendelenburg if you're doing a Morrison's pouch view or a pelvic view, and you can do serial exams, and that can really help. Now, I hope you have enjoyed this video. We've gone about 20 minutes, so let's stop here. Remember, this is an introduction to the EFAST exam. This is not a comprehensive lecture. Therefore, please go and do some reading in regards to the EFAST, do some more learning, and most importantly, go practice this in real life.